it is my pleasure to introduce Dr. Champlain. Not only is she my doctor, but also an expert in HIV, which I found out when I went to go see her as my GP, and we started talking, and surprisingly, the very first doctor who ever asked me not just about my health, but asked me about what my life is like and what do I do. And I told her that I have a husband, and she started drilling into that. And when I told her that he had dementia, that I was his caregiver, that she said, well, we need to take care of both of you together so that you can continue to care for him. And that's the first time a doctor's ever said that to me. And so when we started talking HIV, and I found out she's an expert in HIV. And I said, I want you to come to this conference.
Yes.
Because if I can have such a profound experience just sitting in her doctor's office, I can just imagine the amazing things that she can share to peers. So it is my pleasure to introduce my friend and my doctor, Dr. Shingles, and we're going to talk about the intersection of HIV and COVID today. So it is all yours.
Hi guys, thank you so much. That's amazing. Rob, thank you so much for inviting me here, and I'm really excited. It's always hard to be the last act of the day, right? I know everyone's tired of it at the conference all day. You're like, all right, lady, like the Mopac starts to jam up. Let's do this thing. So we're gonna try to keep it moving. Before I was a physician, I was the assistant principal of a private school. So education is one of my favorite things. So off we go. So what we're going to do today is we're going to review the medical evidence. I'm going to do a lot of virology, epidemiology. I know that Dr. Wright did some treatment and some of that, so I'm going to just sort of touch on that briefly, but instead we're going to do some more basics. We're going to talk about the medical evidence surrounding HIV patients and their partners, friends, loved ones, everyone, in regards to SARS-CoV-19. And we'll review recommendations for the prevention in all persons, but especially those living with HIV. I do not have any relevant financial or other disclosures of interest or obligation, but if the people that make Truvada or Descovy are out there and you want me to speak for you, like I'm so here for that. Take care, everybody. Kinda. I am a member of the Diabetes Speaker Bureau for Novo Nordisk. Diabetes does increase the risk of severe COVID, but that is a different talk. Okay, so first we're going to start with the review. Come on, memes. All right, so let's talk about this. So I think naming things is appropriate and understanding what things stand for, and I think that when we really, it's super important for us to get people's names right and people's pronouns right, and to treat everything with respect because names have meaning. And so I think it's important for us to talk about SARS-CoV-2, which is the virus that causes COVID-19. That is a single-stranded, which is a forward-reading RNA virus, which means it goes from RNA to RNA. We're going to talk about it. There'll be a test later. COVID-19 is coronavirus disease of 2019. Okay, you can contrast this to HIV, right? Human immunodeficiency virus, the virus that causes AIDS, which is acquired immune deficiency syndrome, and of course, HIV is a single-stranded but a reverse-reading RNA virus going from RNA to DNA, right? So just from the very start, we know that there are differences about these two families of viruses and the type of virus that it is, right? Because people like to say things like, well, I can get the virus but then not have COVID. Yes. Why do some people get the virus but then they don't get sick? It's a great question. Why do some people live with HIV for 30 years, right? So we're gonna kind of let's get into it. All right, let's talk about how viruses attack. So the first thing, viruses, they carry nothing besides genetic material, okay? So essentially the first step is it has to find the host cell, whatever that cell is. So if it's HIV, the host cell is the T cell from the immune system, right? If it is coronavirus, it is a lung cell or a respiratory tract cell, okay, where it's trying to gain entry. In the second step there, it goes ahead and attaches and injects its genetic material, blueprints, instructions, to build more viruses. Guess whose resources it uses? The cell, right? It's going to use the cell's own resources, makes a bunch of copies, makes a whole bunch of them. They all assemble, they auto-assemble. And the way viruses assemble is super interesting, and it's a target for how we treat things and how vaccines work, which is interesting. Step 5, release. Guess what happens to the cell when all those little viruses come out, right? So the cell that got infected, unfortunately, gets sacrificed when the viruses come out, okay? All right, so that is a very crazy picture. Stay with me. This is the specific SARS-CoV-2 life cycle here. And so the key points that I would take away from this sort of diagram when you see them in particles is that the virus uses the cell's own resources, that the viral assembly takes time, and then they release all at once, popping the cell. Respiratory lining usually, okay? The highest viral load is during viral release, okay? And high viral load, guess what? High rate of transmission, okay? So not this again. Oh my God, you guys are like, come on. I know. So why do we study this though? We got some target steps here. Those receptors that it binds to on the cell we're looking at. And then of course, translation and replication of the genome. That's how most of your antiretrovirals work, right? With HIV. So all of these steps, when scientists go through all this, we understand the life cycle of this thing. That's how we can really get in front of it and beat it. Okay, and that's how we can answer questions when our patients, when our colleagues, when our friends have concerns about medications or any of that, where we say, well, so it doesn't affect your DNA. It's an RNA virus. It doesn't have anything to do with DNA impact. And let me explain to you why, right? And so these sorts of things can help us. But from this diagram, I can understand why some people lose smell and taste, and it's because where that virus binds, see that ACE2 receptor in the upper right? For me anyway. Left for you guys. A little bit dyslexic, here we go. And so essentially, there's a lot of those receptors for some people, like in their tongue, in their olfactory area, all of this. And so if a bunch of viruses gain entry there and pop the cells of that lining, or it's the nerve root that transmits those signals, guess what? They can't taste or smell anything. And so that's why that's a very common sort of thing, because where the sort of cells with that sort of key on the outside for the virus to bind to, guess where they live, right? Smell and taste. And then anti-HIV meds work by blocking, not allowing HIV to switch from RNA to DNA and then integrate itself into the T cell's genome. All right, so this also plays into why do we wear masks, okay? So essentially, viruses want to get into this respiratory epithelium. The receptors for this virus to get into cells are really concentrated in the respiratory system. And so essentially, airborne and contact droplet is how we get this, okay? So you can wipe down your groceries from HIV all you want, but you are not decreasing your chance of getting an airborne virus, okay? So entry is going to be eyes, nose, mouth, throat, and airway. Patients are like, well, I don't really want to wear the mask. What about my immune system? And I'm like, what about your immune system? Let's talk about it. So your immune system, when people are really talking about that, we're talking about B cells, right? And T cells. Both of those kinds of cells are born in the bone marrow, and then they train in various parts of the body. T cells named for the thymus, the tonsils are an immune organ, the spleen, and the lymph nodes pretty much are where the cells are grown and stored. So B cells versus T cells, both are white blood cells, okay? And they get around the body via the bloodstream or in the lymphatic system. So on average, people have up to about 10 billion different B cells, and on average 25 million to a billion different T cells. And the majority of your T cells are made by the time you're in elementary school, okay? So super interesting, but they do different things. So B cells, their job is to attack invaders outside the cells. World famous for making those antibodies that everyone wants to tell us about, right? And then T cells, their job is to literally go up and attack infected cells, okay? So, for example, patients say things like, well, I heard that if you have a different blood type, that would affect your response to coronavirus. I said, well, let's talk about it. The blood type is your red blood cells, and a red blood cell is it's an inner tube that holds oxygen in the middle, right? And it delivers oxygen throughout the body. And so your blood type has to do with what sort of sugars are on the surface of your red blood cell. And that's not part of your immune system, right? Your immune system is the specific immune system is your B cells and your T cells. That's the other kind. That's your white blood cells, right? They're born in the bone marrow. And they're like, oh, well, that makes so much sense. And I'm like, yes. So it's really, when we sort of get back to basics, I think it really helps all of us to refresh these things, because then when we're reading articles or looking at diagrams, then we're like, well, that doesn't make sense. And then you're like, I know why it doesn't, because that's the wrong one. They've got that twisted. Yes. All right, let's talk about how the B cells work. So antibodies don't kill anything, all right? So people are like, I had coronavirus already once, and I've got antibodies in my bloodstream, and so everything's fine, right? And I'm like, well, what did I just say? The thing wants to attack you in your respiratory epithelium. There aren't any antibodies there, baby. The antibodies are in your bloodstream, okay? So the first step of the response to this virus is the T cells in the periphery, your killer cells, not the B cells that make antibodies. Antibodies are good, they're super good, but that's a different thing. And the T cells do interface with the B cells, because guess what? The T cells are part of the first part of the response. Also, when I was talking to you guys about lymph, obviously the bloodstream, okay? So in the bloodstream, that's how there's all your cells circulate. You know how your blood circulates, your heart, right? Well, how does the lymph move? Well, the lymph moves from muscle contractions, from moving. That's why doctors say things like, y'all gotta move, we gotta walk, we gotta do the things. Also known as, why is it bad to lay in a hospital bed? Okay, because you're not circulating that lymph, you're not moving that immune system, and we need that to do things. So that's why doctors are real mean about getting people up and walking them. We send in the mean physical therapists. That's our other we got our whole team of meanies to come and, coordinate your discharge. We got our social workers and our nutritionists. We got this whole team of people. But to move your lymph, you've got to move your body. And so that's sort of a fun little fact. But so your B cells, all right, so essentially the way this works here, the antigen is the bad guys, so that little star there, it's kind of like the Chicago flag. So this one sort of amused me because I'm from Chicago. So I was like, look at that, that's kind of northerner for us. So B cells all have a receptor on them, and it's kind of like a lock, okay? And then antigens, the bad guys, are kind of like a key. And so you'll notice that in this first one on the left here, that kind of star-shaped dude isn't close enough to bind to that bottom one, but it fits on that top one. So it's kind of like Cinderella and the slipper a little bit, okay? Also, I don't recommend that Cinderella go with the prince, because this man can't even recognize her without makeup on. Like, what is that, right? Crazy. It's rude. Anyway, so the plasma cells, with the help of the helper T cells, they become a plasma cell. Plasma cells release antibodies. Antibodies literally are like that awful slime that people give your children at birthday parties, and it literally sticks to everything that's neutralized. So it makes this big clump of neutralized viruses. And so then this macrophage has to literally eat it up, okay? And so your body can go right ahead and make all of these complexes with the antibodies and the antigens, okay? But that virus ain't dead, baby. It's just stuck to those antibodies. So the macrophage is your body's garbage disposal, and this is it's kind of a fun thing to do later, but you should Google macrophages eating things under a microscope. Good times. You can literally watch this under these things. You're like, holy cow, look at my immune system. Yes, it's so fun. But the way that it works, so the macrophage goes ahead and it picks up those viruses that have the antibodies attached to them. It's got a little bit of a chemical in there, sort of like bleach, goes right ahead, combines the two, and then spits it out without popping its own self. But I always thought about macrophages like Pac-Man. You know, literally, phagocytosis means cell eating. Macrophages are not, they're not a specific part of the immune system, okay? Their job is to eat things, get rid of things that the B cells have brought to it, okay? So just like stomach acid or like hair or any of that, like it's non-specific, it's there to help you defend, but it's a part of what this system is. T cells. We definitely have to talk about T cells in an HIV conference because the T cell is like grand central station for HIV, right? So here's what's going on. So T cells are pretty neat. They find cells displaying signs of internal infection, okay? Once that T cell does that, it makes a bunch of copies of itself. That's why it's called a helper T cell. So it's like, hey guys, I found this cell displaying this messed up spike protein. We gotta make like 10 more of me because this is not cool, right? And then those 10 make more, and then those guys. So cells are really interesting the way they work. So whatever's going on inside the cell, okay, it comes out on the outside. It displays it on the periphery, okay? So it's like got its little name badge out. It's kind of got what's going on. And so imagine the virus is in the inside of the cell, and it's making all these parts. So it's got all the leg parts over here, and all the RNA parts over here, and all the tail parts over here. And so the cell, like the dudes that go ahead and display stuff, they come, they get a piece of that, and they're displaying it on the surface of this cell. The T cell's like, hold up, what's going on in there? Okay, and that's how it knows. So literally then the T cell goes right ahead, marches right up and kills that cell. Unfortunately, that's like the lining of your lung or your nose or your whatever. This is true of any sort of viral infection. So, you know, sometimes we're like a little bit like, oh God, like I woke up and my throat was a little scratchy, but then by the middle of the day I was better. Well, it probably wasn't very many throat cells that needed to be killed. Okay, so yeah, I mean, things regenerate on your linings pretty fast. Do you ever have a little sore inside your mouth and it gets better really fast? Because the life cycle, the time to replace those cells is pretty short. All right, T cells, you guys. This is part of why HIV is so terrifying, is that HIV attacks and invades the T cells. This is also what took us so long to figure it out, because we didn't realize it was inside the T cells. So, I mean, it's like on those terrible, scary movies where they're like, the killer's inside the house. The killer's inside the house. Okay, so HIV invades those T cells. When the HIV virus gets released from the cell, it's the T cell that dies in the process. That's a problem. That's why the T cell counts are such a big deal to us all the time. Okay, so that's part of why counts for CD4 and CD8 types of T cells, helper T cells, natural killer cells are part of those 4 and 8 subsets. That's part of why it's the definition. Okay, so this is sort of where we start to get that link between HIV and COVID because of T cells. Back to COVID. All right, so let's talk about it. This is a busy slide too, but stay with me. So we always say to people, like 5 days before you actually start to have symptoms, you're actually pretty contagious because the virus is busy replicating and the T cells have to respond, or they don't respond, right? And then once we get going there, the illness symptoms start about day 2, day 4. Notice that antibody response, your B cells there, don't really start kicking in until day 5, day 6, the antibody levels. So early on, doctors noticed that when the antibody levels were high, that those patients tended to be sicker, right? Because they had high antibody levels sooner. Why? Well, because they had to. They didn't have a good T cell response in the beginning. Okay? And so that's also why a lot of times people will be like, I want an antibody test to see if I had coronavirus. And I'm like, okay, but that doesn't help you. Because that antibody one, that B cell story you're talking about, that's in the second half of this thing, my friend. The first part has to do with your T cells. Okay? Part 2, why do we wear masks? We're back to this again. Source control, okay? So why, like, essentially risk reduction, reducing the risk of something is more important than absolute prevention, okay? So when you're wearing a mask, And essentially large droplets evaporate into smaller droplets that travel farther, okay? So other examples of risk reduction, condoms, right? Those are 100% effective, right? Seat belts, right? So all of these sorts of things, and I think it's important to emphasize to patients and to clarify that sort of thing in our own mind, that there is nothing that is 100% without risk or 100% effective. And to expect things to be that way is, I mean, it's just, it's unreasonable, right? And so I think that just from a common sense sort of approach, you know, your T cells, most people's T cells can probably handle a small titer of just about anything, okay? All right, let's talk about HIV. HIV biology, so essentially HIV integrates itself into the host DNA. The host cell is the T cells. Reverse transcriptase, which is the magic formula for converting RNA to DNA, is unique to retroviruses, okay? So that is not something that your cells normally have, which makes it a really good target. And I just really liked that picture because it showed the CD4 receptors really beautifully there, because the virus specifically, HIV is specifically looking for those T cells. And that's how it identifies where it should go. Just like the coronavirus is looking for certain types of receptors in the respiratory lining to dock nicely, penetrate, get all of its genetic material in there and make a bazillion copies of itself, right? All right, so again, no use of DNA anywhere, okay? The target cell is not an immune cell with COVID, and it does not integrate into the host genome because again, there's no involvement of DNA here, and your cells are DNA based, okay? So RNA viruses are actually pretty basic. They just bring RNA so that they can make the proteins or make more copies of themselves. All right, this will help us understand the vaccine later, but essentially DNA is the blueprints for the city. It's the master plan, okay? It is set in stone, all right? It's your biological fingerprint. Every single cell has that DNA, okay? The mRNA, messenger mRNA, it's building instructions. It's a how-to, okay? It's like, here's how we're gonna build this, all right? And then your proteins are the actual buildings, the final products. And so this is true for everything. So if I'm the pancreas, the DNA in those pancreas cells is gonna say, here's how we build insulin. Insulin is these specific amino acids in order, and so it goes ahead and the mRNA goes into the ribosome, which is a building machine, like essentially a factory, gives the ribosome those instructions, and out the other side comes insulin, okay? So it's just that easy. So again, this is why this is so important to us is that essentially the big thing about just again comparing these two things, so DNA to RNA to the protein, okay? So coronaviruses, like every other RNA virus on the planet, just copy its RNA directly to proteins. Boring, right? But HIV converts its RNA to DNA, it goes backwards, right? And that's why it was so hard for us to find initially, because the virus had integrated itself into, first of all, an immune cell, and then it's hiding in the DNA of the immune cells that continue to function normally, right? So, super interesting. All right, let's talk about epidemiology. So, just sort of doing an update about the global HIV epidemic. We knew that worldwide, people living with HIV in 2020 was almost 40 million. About 1.5 million acquired it in 2020. People dying from HIV-related causes, somewhere around 500,000. This is the World Health Organization. And then it has it sort of organized by folks here. So obviously it's mostly adults. In other countries, not so much here, there are a lot of children living with HIV. So interestingly, worldwide, more women than men, which I thought was sort of interesting. What about the US? Y'all. We got some work to do, everybody. The South dominates new HIV diagnoses in the US. So essentially, HIV continues to have a disproportionate impact, particularly on racial and ethnic minorities and on men who have sex with men, okay? And so it's important for us to know those things because when we're trying from a sort of social justice standpoint of helping folks, we have to know sort of who is getting crushed by this the most, okay? But we're doing a good job, okay? This is important. So from 2015 to 2019, new infections among young gay and bisexual men ages 13 to 24 dropped 33% overall. That's fantastic, okay? So like, everyone needs to cool it with the millennials because they're getting it, they're doing it, they got it, okay? So they're on it. So we like that. Declines in young men of all races. Okay, the kids are better than us, everybody. They're doing awesome. In Texas, let's talk about COVID. So, for example, this was a couple of days ago because somebody, Rob, made me submit my slides early. So essentially, we've got about 4 million running total cases confirmed, about 73K deaths. So, you know, we continue to have a fair amount of these sorts of things. I know from practicing more rurally that certainly there's a lot of folks that do get coronavirus and we don't diagnose it in time. One of my favorite things to talk about is people be like, well, I went to the hospital for something else and I got admitted and they tested me for coronavirus anyway. And I'm like, okay, well, if something bad happened to you, which is something that happens to people at the hospital, and you unfortunately passed away, if you're positive for COVID, we can't have your organs. So we have to know whether or not you have COVID like right now. Because unfortunately, if you croak here at Seton, we can't use your organs, we need them. So we had to know whether or not you had coronavirus. They're like, oh, that's not a very exciting reason. And I was like, man, how do we diagnose these things? All right, so just like we said, spoiler alert, because of the biology, right? Why do you swab noses? Well, why did Banksy rob banks? It's where the money is, right? So if the cells are gonna be in the nasopharynx, we need to collect respiratory secretions. People are like, I had a test and the doctor swabbed my brain. I'm like, well, some tests only work. I'm like, you had a brain? That's exciting. Diet Coke, it's a blood type. Right? Okay. So the nasopharynx, some tests you have to get all the way back to make sure that you're getting enough of a sample. Other tests are actually pretty accurate if you just swab the front part of the nose. People don't like that. It's like you're picking their nose though, so I'm kind of like, I can do it fast and it's gonna hurt a little, or I can swab the front of your nose for a hot minute and we can have an awkward conversation about brunch, right? So, I mean, whatever people wanna do. What's really important is that you can have a negative screening test that does not rule out the possibility of infection. So people really hate that idea, but this is the way tests work, ladies and gentlemen. Same thing with HIV. Okay, so screening tests err on the side of false positives, okay? So I have a patient and they're like, oh my God, I took a test at home and I tested positive. And I'm like, oh my God, okay, well, let's do the blood tests and not this other stuff here and let's see. Because there are a certain amount of false positives all the time. So you have to do a confirmatory test, okay? And so same thing with this. People are like, I did one of those rapid tests and it was positive and now what do I do? And I'm like, well, you need a real PCR test. You gotta confirm, because we gotta make sure. One result does not make any sort of diagnosis, my friends, depending on what kind of test it is, okay? Timing's important. So if somebody is symptomatic and they think they could have coronavirus, okay, infection, they're concerned, they should get tested, right? They have symptoms, okay? But what I always say to folks is, no, I have no problems swabbing you for coronavirus, let's do it. But I want you to close your eyes and think about the other things that cause high fever and sore throat and problems, okay? Because what also presents kind of like a cold, especially in a young man? HIV, right? It's like a kind of like an awful high fever, sore throat, I don't feel good, right? So we can't miss it. Strep, bronchitis. I had a young woman that was having headaches and nausea, and she's like, do I have coronavirus? And I was like, when was your last menstrual period? Okay, so I think we have to think outside of the coronavirus box a real lot here, and remember that all the other things continue to exist alongside this. And COVID is not going to leave us. It's gonna be here for the rest of our careers. We're going to be talking about this. We're going to be managing it. It's happening. So I know. I heard some go. All right. I know. So essentially, if you don't have symptoms, you have to wait for 5 days. Patients hate this. And in part, it's not your fault. Like, it's political now, which it didn't have to be. But your job, your school, your whatever, they want that test right now. Well, a positive test 3 days after your missed period, it doesn't mean you're not pregnant, Susan. It's too soon, okay? Same thing with this guy here. I'm not finding your nose yet. There's not a high enough viral titer for me to find it in a random booger, okay? It doesn't mean you don't have it. It just means I can't measure it yet, okay? Okay. In terms of the HIV test, blood test is the gold standard. There is a window period, and we can talk about it, but anybody thinks that they have an exposure, they should be tested ASAP. And they should receive, obviously, post-exposure prophylaxis, all that kind of good stuff, right? If they're not already on some sort of PrEP or whatever, and it's a high-risk exposure, okay? I would err towards, let's go ahead and let's treat it, let's do a thing. All persons should be advised to recheck in 90 days due to the window period, okay? And that's also why, right, doctors are like, you have to get a blood test every 3 months to get your Truvada or your Descovy. Why? Well, because there's a 90-day cycle there. Come on, there we go. Okay, what I was just saying, not all colds are COVID. That is not shingles. That's the HIV-1 seroconversion rash. Looks just like shingles. And it can be that's on the back of a leg, actually. I took that picture myself. And the patient's mother comes in with him, and she's like, he was so sick, he had a high fever, he laid around, he felt bad, and now he's got this rash. Is it shingles? And I was like, huh. I was like, I'm gonna examine him, why don't you wait in the waiting room? And I was like, hi, so I know we just met, but I have to ask you a lot of personal questions, because I don't think you have shingles. And the patient's like, I don't think I have shingles either, thank you for sending my mom to the waiting room. And I'm like, okay, cool. But some patients, if they're not thinking of that, and they've got a little stripe rash, they're like, well, I definitely have shingles. Even worse, telemedicine. No one actually examined the patient. They're just holding like the little arm stripe up. My God. And guess what? That's even harder to see if your patient has dark skin, right? And so that's another thing too with medical education. I have some pictures that are more diverse than that, but this is the most obvious one to see, so that's why I picked it. But it's just now that we're starting to get pictures where we see dermatologic infections on people with skin that's not white. So that's been very helpful for us, because it's like, oh my God, I never saw that until I was actually practicing. Oh my God, how many did you miss before you actually saw what it looks like, right? So essentially, this is kind of a nice diagram here. Essentially, nothing in general, there are very few tests that can detect HIV before day 10 in most cases. Okay. Sometimes we'll catch it just sort of depends. But pretty much after that, we can get it. But I always say to people, if somebody you know is at risk, and they seem to have a cough or a cold, not feeling good, especially with the bad swollen lymph nodes, and the real achy joints and all of that, it makes me really nervous that it's not COVID. Okay. All right, let's talk about the diagnosis of COVID-19. So COVID, the disease, D for disease, that's a clinical and a laboratory determination, okay? So, and we have to have a positive PCR test to meet a definition, but essentially the patient has to have a case presentation, compatible symptoms, right? And they have to be positive, okay? What is AIDS? Okay, so AIDS is also a clinical and laboratory determination. You have to have a low T cell count and something has to be happening. There's a specific infection, okay? When there's not T cells, you can't defend against certain kinds of bacteria and viruses. Surprise, because the T cell can't coordinate with the B cell, right? That's that whole division of the immune system's down, okay? Specific cancers, right? There's definitely HIV and AIDS associated cancers and illnesses, right? So I feel like the one that patients know the most is like the movie Philadelphia with Tom Hanks with the Kaposi sarcoma. Okay, they all knew that that was a problem, right? And so by the time you're seeing these sorts of things, by the time the patient gets PCP pneumonia or Kaposi sarcoma, their T cell count's already getting low, okay? We don't get that far these days. We're way in front of it nowadays. But it's, again, a clinical thing. So people are like, oh my God, Dr. Champlain, I tested positive for coronavirus, and then I got a confirmatory test, but I feel fine. Now what do I do? I mean, panic, probably. Well, you don't have COVID. How do I not have COVID? Well, you don't have any symptoms. You just have the virus, right? So if you start to get symptoms, then we could consider taking the risk of one of those treatments that Dr. Wright told you about. We could consider giving you antibodies or giving you a novel viral treatment or giving you something like that. But there is a risk associated to that treatment. And you just told me that you want me to treat a blood test. Oh, okay, cool. I mean, other than that, like Tylenol, rest, stay away from other people. You still have to quarantine, right? Like you could be spreading the virus in your secretions, even though you're not feeling bad. Like good for you, your T cells are killing it, right? So, and a lot of us that have had the vaccine, and we'll talk about it in just a minute. I mean, shoot, I've probably had coronavirus like 3 times today already, right? I swab people that have it. I see patients that have the worst kind. Okay, so you all are like back up. Yikes. Medical conditions that are high risk for COVID-19. This has been a really hot topic, and what I advise here, as always, is common sense. So, but first, to understand why certain medical conditions are high risk, let's talk about the bad things that happen, also known as, but did you die? So, severe respiratory distress syndromes, SARS. Okay, I'm 40 next week, and I remember when I was in college in the early 2000s, remember SARS? Okay, and that was the first time we really saw SARS, which has a definition. Hold tight for me. But it was caused by a virus that was kind of like the swine flu, and there was like a bird or a monkey or whatever. I wasn't in med school yet, I don't know, but the virus caused SARS. Okay? Systemic inflammatory response syndrome, SIRS, which leads to sepsis, and then obviously hypoxia, all this kind of stuff. All right, SARS. So essentially, how do we treat it when people have SARS? Severe acute respiratory syndrome, okay? And so around February 2003, we talked about things like this. People had a temperature over 100.4, and they had symptoms of respiratory illness, and they had a close contact within 10 days with someone that we think had SARS, or they went somewhere where they're having a SARS outbreak, okay? Because we didn't have a good test for it. But pretty much those things made us think. But let's talk about it. So what's the treatment? What are you gonna do about it? And that's something I always advise the medical students. What are you gonna do? Let's think about what we're gonna do. So we have to stop the fever. Why do we treat fever? Well, because when your body is extra hot, it doesn't really help your immune system for most infections. In fact, you're losing more water everywhere in your body, okay? So that's why people that feel hot and miserable, what they don't like to do is take fluids by mouth, like your kid. Okay, so people are like, oh, I'm gonna let my kid sweat it out. And I'm like, please don't do that. Like, I believe you that your child has a fever. Give your child Tylenol or ibuprofen, please, and make them comfortable so they will take fluids by mouth, because what I don't want to do is give your kid an IV. That's a terrible way to get fluids. It's true for you too, okay? So, and it's hard to drink when you're hot and gasping, okay? So when people really are starting to breathe heavy, we got to give them fluid support to keep their blood pressure up. Because of that thing I just said, the heart has to pump the blood, blood has all the things in it. And if you're having a hard time, we got to have plenty of volume there. We give oxygen, we provide anti-infectives, stimulate the immune system with steroids, and avoid worsening those chronic conditions. That sounds easy, right? Who wants to go to medical school now? But so all these sorts of things have a purpose that's based upon what is happening to try to support that person. But all these things that we do, the patient's immune system still has to do the work. I can't make your B and T cells do anything. They have to do it. Sepsis. Sepsis is a problem. So a couple of things, and this is part of how patients are getting very, very sick in the hospital, not just with coronavirus, but with any sort of infection, is that you get an infection in the blood, the inflammatory response can be really, really, really big. And it's actually the inflammatory response that becomes the problem. Not the infection, the body's response. And that's the deadly part. There's this whole thing about surviving sepsis. It's a protocol. It came really into, I'd say, fashion probably when I was in medical school, right around like 2007, 2008, because we were about 4 or 5 years into the SARS thing, and we learned that if in the first hour of presentation, you could identify these people correctly and get the medicines into them, they didn't die. Okay? And so people have to realize that the patient has this inflammatory syndrome. Generally, the paramedics started it by getting the large bore IVs in people, putting the oxygen on them. All of that is the start of the surviving sepsis idea here. The problem here is that it requires staff. You need nurses and doctors and pharmacists and lab and phlebotomists to get this going. But what's the problem right now? Well, we don't have enough people in the hospital all the time and enough resources and things. This is a very resource-heavy protocol. It's extremely effective, but you need an entire team of people. It takes about an hour, and a nurse needs to monitor this person constantly. Because besides getting fluids into them, we've got to measure all this kind of stuff to keep this person alive, just from their response to the infection that's now crossed into their blood. Of course, there's overlap all the time. So there are all sorts of things that can cause an inflammatory response. So people covered in burns, someone who gets in a car accident, someone with pancreatitis, infections, all this sort of stuff. And so you think that SIRS is sort of the precursor to sepsis, okay? And so that's why immediately when patients present with fever, rapid heart rate, dehydration, they're looking bad, they're confused, why it's the IVs and the fluids and the antibiotics and the steroids and the whole thing, because that's all part of a protocol to support the body so you don't kill yourself with your own response. What do you need to survive SARS, SIRS, or sepsis? Well, you need your lungs, your heart, lymph nodes, blood cells, all your hormones, all those sorts of things. Okay? Any health condition that weakens any of those systems, guess what? High risk. So it pretty much, it makes perfect sense once you think about it. If these are the systems we need, so if Dr. Champlain, I get so sick that this thing's in my blood and starts to threaten my life, what am I going to need to get better? Well, you're going to need these organ systems to work right, and we're going to need to be able to resuscitate you quickly. So if you have something that affects this, like I've had diabetes my whole life. So imagine how hard it is to fight an infection if someone's blood sugar is 400. That's a lot of food available for attacking pathogens. I'm like the Four Seasons buffet. I mean, I don't know. I'm probably more like the Stockyard Stampede or whatever that place is, right? It's fine. Sizzler. Okay, so, or, imagine somebody's lung already, the inside of the lung is already always a little bit swollen, And so the diameter of that lung, that airway is smaller because of their chronic asthma. And they haven't seen their doctor in a year because of coronavirus. And now they haven't been applying that anti-inflammatory, that inhaler they're supposed to take to prevent things. And then they breathe in a mouthful of this stuff at the HEB, because HEB is literally the best. You guys have the best grocery stores here. I am not mad about HEB. Amazing, right? So our asthmatic friend gets a mouthful of coronavirus at HEB. Sorry, HEB. And it goes ahead and it's in that respiratory lining, that swollen, awful respiratory lining. This is not good, not good. You already have diminished lung capacity from that disease, asthma, okay? So again, like this is how we determine, well, so, all right, I don't want to go there quite yet. Okay, so essentially, if the treatment is going to be hard for you to take, like steroids, if they gave me steroids right now to try to help me, it'd make my blood sugar like 600, 800, 1,000. You can't give me steroids. The steroids will try to kill me. So what do I need to do? Avoid problems where I need steroids. Okay? So again, if the treatment would be difficult for that person based on their medical condition, or the disease would be hard for their body to fight because of their medical condition, or the treatments that are available are incompatible with the medications or other treatments that they have to take to live, now we've got a problem, Houston. And they're like, not funny, keep going. All right, let's talk about living with HIV. So essentially, I did a lot of research on this because I've gotten a lot of questions. There are no identified interactions between the viruses at this time, between HIV and SARS-CoV-2, okay? They're not friends, you can't sit with us. But they work differently. They're different viruses. I spent a long time living in this presentation sort of explaining that to you guys to make this point right here. So HIV is latent or embedded or hiding in the DNA of the patient's T cells, but the link here, T cells are needed to stop the replication of SARS-CoV-2 in the early phases. The World Health Organization report examining data found that HIV is an independent risk factor for severe or critical COVID. Well, let's talk about, I was like, let's see. Let's talk about the United States data, okay? So one of the things I kept seeing over and over again is that unfortunately, people with HIV are overly represented in many of the demographic groups that have been hardest hit by the COVID pandemic. So the same groups that are disproportionately affected by HIV are also disproportionately affected by severe coronavirus. So what I would say about that sort of thing is correlation does not cause, causation, right? Like that doesn't necessarily mean that there's a link between those two viruses, but I think we have a public health situation now, right? So people with HIV may be at higher risk because of their representation in these groups, not because of anything in particular about HIV or about coronavirus. Okay. Also, like, I just have seen that and being like, oh, this is so bad, you guys. So we want to really, I think that it's super important from a trauma-informed standpoint and from just a general social justice standpoint to be really, really clear on this sort of thing and really make sure that we're providing really outstanding care, especially to these ethnic groups and then especially to underrepresented persons. All right, people with control of HIV are lower risk, and we all know this is a project, okay? So we have to support patient compliance with that medication therapy. All right, so also what I always say to patients, I'm like, listen, I don't take my medicine 100% of the time for my type 1 diabetes that's been trying to murder me for 37 years, okay? Taking medicines is hard, and there are a lot of reasons why you can miss doses of your medicine. But we have to be compliant with the medicine as much as we can, and let's go there about it, right? So about 60% of people with HIV report 100% antiretroviral therapy dose adherence. So, 4 out of 10 of those people are being honest, and 6 out of 10 of those people are lying. Okay. Over 1/3 do not have sustained viral suppression. That's not great. That is not great. Because now we're letting this thing have a chance to get where? Out of the T cells. So it can do what? Go get more T cells? That's not good. But there's a lot of things happening here, right? So the gaps in the preventative and follow-up care have been bad, right? Like Ryan White Center providers reported that nearly 1/3 of their centers closed at least temporarily. So people didn't have the health care they needed. Client and staff trauma from COVID-19. So problems with staffing, interruptions to client staff therapeutic communication and treatment. Just sort of there's been a lot of trauma towards healthcare providers and our team members that are social workers and therapists and counselors and the sorts of things that you're having to hear. Secondary trauma from listening to these stories, things happening to people that we've never seen before, right? And then having to try to think like, what do I do about this? How do I feel about this? And then people were afraid of attending medical clinics due to risk of exposure to the virus. I think when patients know kind of how medicine works, the medicines, they stop the unique to HIV, the reverse transcriptase from working, so that thing can't integrate itself into the DNA of the cell. Okay, because it can't get into the cell's DNA if it can't turn itself into DNA. What turns it into DNA? Reverse transcriptase. What is stopping it? Truvada, or Atripla, or whatever, right? Kaletra, back in the day. Many treatments now are a combo of 2 or 3 different viral stoppers in just one pill. And that's totally amazing, okay? And so explaining, I think initially there was a whole lot of things like, oh my God, resistance, right? And everyone was really stressed about it. And I think it's very important to explain to patients, yeah, resistance is a thing that could happen, but you've got 2 drugs in that one pill. If you miss 1 or 2 or 5, forgive yourself and start taking them again. It's okay, it happens. It happens. But the important part is to be like, oh my God, I missed some pills. And then be like, well, I have to start taking the pills again, right? Let's just, okay, yeah, oops, right? Other things that happen here, I think that when we understand the whys, then there's less judgment from providers and you're able to have more solutions from the patients. I'll say to the patient, like, tell me why you're not taking Descovy every day. Well, I feel fine, Dr. Champlain, and my partner that has HIV, like their viral load is suppressed. My friend, if at any point it is not suppressed, you know Murphy's Law that's when you're going to forget the medicine. So I need everybody to be taking the medicine, right? And so complexity, when people have to take things more than a few times a day. I also think it's important to ask people always want to buy all this stuff over the counter, right? I'm like, you guys, no one's checking what's in your over-the-counter vitamins. It's not regulated at all. It's regulated as much as lipstick, not at all. We can all argue about the FDA. It's a low bar, but it's a bar, everybody. Okay? Ooh, a bar. So essentially, right? So if patients, what's so interesting is people will be like, my friend said that I should take all this vitamin C so that they won't get sick, and she works in a school, and I'm like, okay, so you remember to take the vitamin C in the morning, and then you told yourself, oh, I took the medicines this morning. What you didn't take is your Truvada. Because your pattern this whole time has been to take that. But instead, you were real excited about taking this supplement that's going to give you a kidney stone. Please stop. And then, then you missed your medicine, right? How do people get pregnant on birth control pills? That's the same story. So it's not the interaction from it. It's that the person thinks that they already took a medicine. Well, yeah, you took a medicine, but it was Bactrim, my friend. It was not orthotricycline. Prevention strategies. All right, how do we prevent HIV, right? So we remember what the transmission mechanism is. It's blood and body fluid borne, right? So PrEP therapies, post-exposure prophylaxis, avoid condomless sex, routine testing, treatment of other sexually transmitted infections that increase the risk, like chlamydia, syphilis, okay? Not sharing needles, prevention of needle sticks in healthcare providers, prenatal care for people that are HIV positive, people with a uterus that might have a fetus in it, okay? Vertical transmission from pregnant people to their babies is still a very important mechanism worldwide. Women, people that are pregnant people here in the United States that receive appropriate prenatal care almost never have an HIV positive baby. The HIV is transmitted in the breast milk though. So that's where like the milk banks are really important, which is super amazing. We've seen a lot of good support for that. What you'll notice is that we don't see a whole lot of concerns about blood transfusion anymore, right? That's the whole Ryan White Center where he got the HIV from the blood transfusion and the whole thing. So super interesting with how that went, but that's not really something that makes the list anymore, which is so interesting. 20 years ago, if I was giving this talk, I'd have to be like, consider blood transfusions. I still think we need to consider before we give people blood products for other reasons, but that's a story for another day. HIV is not transmitted by air, water, contact, insects, pets, sharing food, water, or toilets. I think we think that patients know this, and they don't know. They don't know, okay? So I had a slide that has a statistic about like 7% of Americans think that chocolate milk comes from brown cows. You guys, that's like a few million people, everybody. Okay, so like education's the thing we need. All right, mask wearing over the nose and the mouth for preventing COVID, avoiding closed and confined spaces, fresh airflow, distance from other people, stay at home when you're sick, vaccines, okay? Little or no evidence of harm. If you don't know how to use gloves, don't use them, please. Vitamin and other supplements, ivermectin, hydroxychloroquine, wiping down phones or surfaces, that's contact. Stop wiping the phones. Now, do some of these other things like, Clorox and wearing gloves properly, do they prevent other things? Yes. Do they prevent COVID? No. All right. People always want to bring up all these things. What about ivermectin? What about ivermectin? Okay, if you were at the hospital and you were like, I watched this video on YouTube and I want you to give that to my grandmother. We'd be like, oh, that sounds fine, let's do that. No, we don't just try things on people, okay? Remember, they did all sorts of things with HIV treatments. It's actually really sexual virgins is actually still a real problem in other countries. Doctors Without Borders still reports a whole lot of violence on that front. Potions, chemicals, oxygen therapies, electronic zappers, like all sorts of terrible things. Can you imagine? And so literally like 10 years from now, they're gonna be like, they were giving people horse antiparasitics. Like, why would they do that? And we're like, oh, there was this man and he was very orange and it's gonna be a real lot, you guys. But here's the deal, is that whatever you're doing, the prevention of the treatment has to interfere in the viral life cycle or it doesn't stop the replication of the virus, period. End of story, right? How does something that treats parasites interfere in that ridiculous life cycle picture I showed you of SARS-CoV-2? It doesn't, okay? Infusing antibodies into somebody, how does that kill SARS-CoV-2? It doesn't. It just binds it, and then the body's macrophages still have to respond, right? How does the vaccine work? Salad doesn't cure COVID. mRNA. So we talked about it already. mRNA is instructions on how to build the protein. So the mRNA vaccine, okay, that's going to be Pfizer or Moderna. It's the blueprint for the spike protein of the virus. Your cells then make and display the little spike protein, and your T cells are like, what's that over there? Huh. And so the T cells activate more T cells versus viral attack, and then they ready their friends, the B cells. Hey, you might see this guy in the blood, and then I need you to trap it. So again, here we go. So the T cells have to go first, and the B cells have to go second. How do we make the T cells work better? We give that mRNA vaccine, which is the little spike protein, so your T cells can practice. All right, so how does this work? So Pfizer and Moderna deliver messenger RNA only. Messenger RNA changes your DNA, my friends. You need reverse transcriptase to get back into the DNA. But stop it, right? That's not a thing. mRNA is a blueprint. It's not that fancy. They give mRNA way more credit than it's owed. It's a set of instructions. It gets degraded after you build whatever it is you're going to build. Okay. Adenovirus vaccine. What they've got is they've got the common cold virus to deliver the spike protein. Okay, so they use that virus to deliver the spike protein. The cell makes the spike protein, and then guess what? Same idea. Okay. So essentially, vaccine development has a lot of stages to it. Phase 3, ultimately all companies with vaccines authorized for use in the US included people living with HIV in their phase 3 trials. Okay. So there were cohorts of patients that had HIV. All of them were well controlled, obviously, but we're starting to see more groups of people included in vaccine trials, right? The other thing that's interesting about this is that the people recruited, the human subjects recruited for this vaccine development was a great slice of the United States. It was a diverse group of people, men and women, people with chronic health conditions. Traditionally, that's not how we do vaccine trials. We do them on the military. How do we overcome vaccine hesitancy? So what we want to do is build discrepancy with the patients, okay? So use familiar examples. Wearing a seatbelt can decrease the risk of death in a car accident by about half. The risk of being hurt by a seatbelt, being trapped in water, or other scenario, that's less than 1%. So again, with patients, like, what's the risk of the antiretrovirals, right? You could have side effects related to taking the medicine, risk of allergic reaction, GI side effects, headaches, nausea. What's the risk of non-treatment of HIV though? So if we define risk as the prevention of a bad outcome, inaction is the most dangerous thing somebody can do. I try to build discrepancy with patients too. You could have problems from the medication, right? Nothing's perfect. Most patients do really well. But what's scary and a little bit of bad news is that if you choose to not take any medicine, you'll progress to AIDS, which is the end stage of HIV, rapidly. And the treatments we use at that point are really uncomfortable. Certainly worse than the risk of your antiretrovirals. And I want you to consider that when you decide to forego this if your reason really is these effects here. Because I don't want you to suffer. I don't want to hurt you with medicines. Okay? Roll with resistance, right? If you're concerned about side effects, right? When mild side effects occur, they are a normal sign your body is building protection to the virus. Okay? Well, the T cells, display the spike protein. You're going to break some eggs here. We're going to pop some cells. The T cells are going to kill some things now because the immune system responded to that vaccine. Some long-term issues after COVID are a big deal. And so I always say, let's not confuse the risks of the vaccine, the side effects to the vaccine, with the side effects of the actual disease. Okay? You can still get the virus if you've had the vaccine. Stay out of the hospital. That's what we're playing for. Okay, so what does the vaccine reduce? It reduces the risk of hospitalization and death. Inpatient treatment, emergency care, okay? Even if you don't have SARS-CoV-2, if you go to an ER because you have a car accident or a heart attack, you can be exposed to others with high viral loads in the most dangerous form of the virus. I don't go anywhere, Dr. Champlain. Really? Because if you have something bad happen, you're going to go to the ER and meet corona, okay? Inpatient floors, we have a lot of issues, including people can't have their family and visitors in the sickest areas. That's a bad prognostic factor. Okay, like having the family there to help us manage in the ICU and on the floors is super important because we can't be everywhere all at once. Risk of hospitalization, adverse drug reactions, drug interactions. We give you the wrong drug, you get an infection, back and neck pain, deconditioning, falls, pressure ulcers. The hospital has a lot of risks. Some confounding factors here. People sick enough to go to the ER or be admitted, they're generally already pretty sick. Okay? Hospital care and outcomes vary. Pre-hospital care varies. Socioeconomic factors also affect long and short-term outcomes. Outpatient treatment. We're almost there, you guys, hold tight with me. Criteria for outpatient infusion therapy. So the duration of infection, how long has the person been sick? We have to intervene at the right part of the life cycle of the virus, or guess what? Those antibodies don't work, okay? And pre-existing conditions would weaken the immune system or make other treatments less effective or increase the risk of complications, right? So your B cells aren't producing yet, T cells all worn out, antibody infusion might be fine, but we have to be on time. Treatment at home, obvious benefits of treatment at home, okay? Especially it being safer for the mental health of most. Most people are afraid to be in the hospital, rightfully so. I just said a bunch of terrible things that can happen to you in the hospital. Here we go, bring it on home. HIV is the virus that causes AIDS, blood, body fluids. SARS-CoV-2, transmission, droplet, and airborne. Prevent disease severe enough to go to the ER or to the hospital. That's our big goal. Avoid transmission to susceptible persons. Decrease dissemination of misinformation about HIV, AIDS, SARS-CoV-2, or COVID-19. Improve adherence to antiretrovirals to keep those needed T cells strong. Keep immune system strong in all patients, right? All the regular stuff. Healthy diet, exercise, good mental health. Stay updated on your heart and your cancer screenings, okay? All the things that could get you can still get you in a pandemic. Update all your vaccines needed, not just for SARS-CoV-2. If it's a man that has sex with men, Hep A and B vaccine series are needed in addition to regular things. And then everyone should get flu and pneumonia vaccines. I have a whole bunch of references for you guys. Any questions? Okay, fabulous. Thank you so much.